Hi everyone, thank you for joining. So we'll just get started in a couple minutes, just letting other people come in. And we're going to be talking today about the golden hour of traumatic brain surgery management. So this will be consisting of how we kind of define what the golden hour is for traumatic brain injuries, and also what type of surgical interventions we can take and what type of imaging is required to kind of determine the golden hour. And then we'll talk about for our well-being section, which will be led by Neha, we'll talk a little bit about resilience in high demand medical fields such as surgery. So just a really, really nice session planned out for you guys. We're gonna wait for like about 3, 4 minutes more just to let everyone else in, and then I'll hand over to Salma. I'll indicate to you when. And then, yeah, we'll start from there. Thank you very much. Okay, I reckon we give it a start now. Salma, could you please take over for the first half of this presentation?
Hi everyone, my name is Salma and I am the Education Officer for the Aspiring Surgeons Network. And as Serena said, we're going to be covering traumatic brain injuries today. So we're going to be starting with different causes and we're going to be looking into primary and secondary brain injuries as well. So starting with primary brain injuries, um, this refers to the immediate structural damage to brain tissue occurring at the moment of trauma. So it results directly from external mechanism forces applied to the skull and the brain during the traumatic event. So it's basically referring to the immediate physical effects of the brain injury. And these forces can include acceleration, deceleration forces, rotational forces, compression, and penetration. And these all physically disrupt brain tissue. So looking into each mechanism, we have direct impact or contact injury. And this happens when the brain strikes the inner surface of the skull. And this can cause focal lesions such as contusions and lacerations. Moving on, we also have acceleration, deceleration forces, and these forces are the rapid movement of the head, which causes the brain to move within the cranial cavity. And this can lead to shearing forces, and these shearing forces damage neuronal axons. And finally, we'll look into rotational forces, and these are twisting movements which cause diffuse axonal injury due to stretching and tearing of axons. And I think we also have an image on the slide coming up. So this image shows both primary injury and secondary injury. Primary injuries can include skull lacerations, skull fractures, contusions, cerebral lacerations, intracranial hemorrhages, and diffuse axonal injuries. And what happens is the primary injury will eventually develop into secondary injury. And this is due to increased intracranial pressure, hypoxia, hypertension, hypothermia, electrolyte disturbances, toxic amino acids, and oxygen radicals, which we'll go into more detail on the next slide. So looking at secondary brain injuries, this refers to the delayed biochemical, cellular, and physiological processes that worsen neuronal damage after the initial trauma. And these processes may develop over minutes, hours, or days following the primary injury, and this does depend on the severity of the injury. And there are a few types of secondary brain injuries. So the first type is cerebral edema. And this trauma triggers inflammatory responses and disruption of the blood-brain barrier. And there are two main types of cerebral edema. So the first type is vasogenic edema, and increased blood-brain barrier permeability allows plasma proteins and fluid to leak into the extracellular brain tissue. And the second type of cerebral edema is cytotoxic edema. And this is failure of ATP-dependent ion pumps, which leads to intracellular accumulation of sodium ions and water. And this can cause neuronal and glial swelling. And what happens is this swelling eventually increases intracranial pressure, which we will look into more detail later on in the PowerPoint. So increased increased intracranial pressure. So the skull is a rigid compartment, and it's got three main components. So brain tissue, which makes up around 80% of the skull, cerebrospinal fluid, which makes up around 10% of the skull, and blood, which also makes up 10%. And according to the Monro-Kelly doctrine, an increase in one component must be compensated by a decrease in another. So following traumatic brain injuries, edema or hemorrhage increases intracranial volume, the intracranial pressure rises, and cerebral perfusion pressure decreases, and reduced cerebral perfusion leads to ischemia and neurodeath. There's also three more types of secondary brain injury. So the first type is cerebral ischemia and hypoxia. So this is reduced blood flow, which leads to insufficient oxygen, and this can cause ATP depletion, which means that less energy is released for the activity of the neurons in the brain, and failure of sodium and potassium ion pumps and cellular depolarization. And the fourth type of secondary brain injury is excitotoxicity. So what happens is, following trauma, large amounts of glutamate, which is an excitatory neurotransmitter, is released. And excess glutamate overstimulates NMDA and AMPA receptors. And this can cause an excess of calcium ion influx into neurons and activation of destructive enzymes. So, for example, proteases, lysases, and endonucleases. And these enzymes specifically damage cell membranes, mitochondria, and DNA. And the final type of secondary brain injury is oxidative stress. So mitochondrial dysfunction and inflammatory responses produce reactive oxygen species and reactive nitrogen species. And these two types of species can cause lipid peroxidation, protein damage, and DNA fragmentation. which all three of these definitely have a huge impact on the brain. So moving on, we have different causes of traumatic brain injury. So as we've said before, traumatic brain injury occurs when these external mechanical forces cause disruption of normal brain function. And this can happen in many different ways. So for example, road traffic accidents, which is one of the leading causes of brain injuries, and is rapid acceleration deceleration forces lead to diffuse axonal injury. We also have falls, which are mostly common in elderly individuals and young children, and this often produces subdural hematomas due to tearing of bridging veins. Interpersonal violence is also a common cause of traumatic brain injuries, and the blunt trauma from assaults can cause skull fractures, intracranial hemorrhages, and contusions. Sports-related injuries are very common in contact sports such as rugby, boxing, American football, and martial arts. And these types of injuries can often lead to concussions or repetitive mild traumatic brain injury, depending on how often one sustains these injuries. And we have occupational injuries, and these injuries are most likely to occur in construction, industrial, and military settings due to falling objects or explosions. And finally, we have penetrating trauma, and examples of this includes gunshot wounds or shrapnel injuries. And penetrating trauma can cause direct destruction of brain tissue and vascular due to the nature of the injury. And of course, the impacts of all of these injuries does depend on the severity of the injury. So moving on to the next section of the PowerPoint, we're going to be talking about examples of neurosurgical emergencies that require immediate surgeries. So the example that we have is a hematoma, and this is a rapid bleeding between the skull and dura mater, which is basically the brain's outer covering or membrane. And this causes severe pressure on the brain and is usually caused by an arterial tear following a fracture. And acute epidural hematoma is characterized by specific symptoms. So usually after experiencing the person may feel fine at first. However, deterioration does occur very, very fast. And symptoms of deterioration can include severe headaches, vomiting, confusion, and most often a dilated pupil on the side of the injury. And how this is treated is a craniotomy is performed to remove the blood clot to stop the active bleeding. And this is a temporary region of the skull called the bone flap, and this provides the neurosurgeon access to the brain. However, this does make this surgical procedure quite invasive. And consequently, rapid increase in intracranial pressure, which can eventually cause a brain herniation where brain tissue, blood, cranial fluid are shifted from their normal position in the brain. And I think there's an image as well showing how the craniotomy is carried out. Yeah, so as you can see, this image shows how the craniotomy is carried out. So first, a part of the scalp will be removed depending on where surgery.
Wait,
And will
apologies,
remove a
Salma.
small skull to have
I think your mic isn't working as well as it does normally. So, would you be okay to join and take over the meeting after, like, I'll just go over some of the slides.
Yeah, that's fine, no problem.
Yeah, no problem. Thank you. All right, so as Salma was saying, we have a craniotomy. So that is, we've already gone over this in our previous seminars, but we have the skull piece has to be removed. And then the skull obviously the skull piece is removed and then the dura mater is exposed. That is a little piece of tissue that is kind of covering the brain. So then that is sliced, which we can see here, to kind of expose the brain, and that's how the craniotomy happens. Craniotomy is not just used for acute epidural hematoma. You would know this if you attended our previous seminars in the neurosurgical series, but it can be used for many different cranial or neurological conditions. And yeah, if Salma, you've joined, you can try and use the mic and see if it works.
Is that any better now?
It's just like a kind of laggy.
I can try joining from a different device and you can
Yeah, I'll
carry
just
on
continue then. Yeah,
do that. Okay, thank
no problem. And then we have the cauda equina syndrome. Sorry, guys. And then, so this is basically a surgical emergency where a bundle of nerve roots at the very bottom of the spinal cord is severely compressed. So obviously, the bottom of the spinal cord kind of provides neurons to the lower half of the body. And so if that part is severely compressed, it could lead to severe leg weakness and saddle anesthesia, which means like numbness in the groin area, or it could also lead to bowel and bladder dysfunction because obviously all types of organs are kind of controlled by nerve signals. And so if the spinal cord is kind of damaged or severely compressed, it will lead to these sort of symptoms. Then we have it's most commonly occurs when a large slipped disc, so that is a herniation in the back lower back pushes into the spinal canal. So this kind of crushes the nerves that control your legs and bladder. And in very severe cases, it can also lead to permanent paralysis of the legs and like the lower half of the body. So so if you so this is like it's severely compressed. So it's not like it's completely cut off the nerve nerve endings. Um so that's why surgical intervention is needed for this syndrome. So then we can kind of prevent the risks that it kind of poses. So we have a sorry for the pronunciation, lumbar laminectomy or discectomy. And so this is performed to kind of remove the material pressing on the nerves. And a laminectomy involves the removal of a section of the bone from one of your vertebrae. So that is just a complicated word of saying spinal bones, so the bones that make up the spine, to relieve the pressure on the affected nerve. So if you know, the spinal cord is right in the middle of the spine, and then we have the spinal bones that kind of protect it in a sense. So those bones could kind of press on this spinal cord, and that can obviously cause paralysis or a lot of dysfunction in a variety of organs in your body. So to relieve, so then a discectomy could also be performed in where a section of the damaged disc is removed completely. So laminectomy is where you remove the spinal bones, like just move them a little, and then discectomy is where you completely remove them. So consequences of delay. So this is when you miss that kind of golden hour of treating quadra equina syndrome, is where you get permanent paralysis in your legs, and you have a lifelong loss of bladder and bowel and sexual function as well. So it can have a huge impact on the person and also the person's quality of life. So this is why neurosurgical intervention is quite important in cases like these, because it can cause, if we don't act on it, this can cause a huge delay. And that delay can cause many permanent problems. So yeah, this is a picture of the quadra equina syndrome, and that's what it's basically showing, is that the intervertebral disc kind of is pressing on the spinal nerve root. So this has been caused by the inflammation of this disc. And obviously this is causing a compression to the nerve roots. And obviously that is going to have an impact on all the other neurons that are attached to that nerve root. Okay, and then we have aneurysmal subarachnoid hemorrhage. So we also went over what subarachnoid hemorrhage is in one of our previous seminars, but I'll go over it again just in case you missed it. So what it is, basically, it's a life-threatening type of stroke caused by a brain aneurysm, so a weak or bulging spot on an artery wall. And this causes rupturing and leaking of the blood into space surrounding the brain. So subarachnoid, the area is basically in the brain. Let me see if there's a PowerPoint. Uh, no. Okay. Um, Anyways, so this type of symptoms that occur with this type of hemorrhage is very specific. Thunderclap headache is very, very known. And almost every patient that has subarachnoid hemorrhage goes through a thunderclap headache. And it's kind of a headache that kind of spontaneously comes, but then it doesn't really leave. And it's described as one of the worst headaches a person can have in their lifetime. Then we have neck stiffness, light sensitivity, and seizures. So with a lot of the hemorrhages that we have epidural hemorrhage, we have subarachnoid hemorrhage, we have intraventricular hemorrhage, we have loads of different types of hemorrhages. And most symptoms are very, very common. And that's why imaging techniques are used to kind of decide where that brain, um, where the bleed actually happens, so then we can treat it with the necessary surgical interventions. So surgery, in terms of surgery, what we do for this specific type of case is that a neurosurgical clipping and then endovascular coiling are the two primary methods of kind of treating brain aneurysms. So clipping is an invasive procedure like most neurosurgical procedures. It's in which a craniotomy is performed. So we went over what that is. It's where you remove the skull, the bone flap of this from the skull, and then you kind of expose the brain. And the clip is placed across the neck of the aneurysm to kind of prevent the inflow of blood. So that is to kind of keep the size, decrease and maintain the size of the aneurysm to make sure that it doesn't grow big again. Then we have coiling, which involves passing a catheter via a peripheral artery into the cerebral circulation and placing a coil precisely into the aneurysm, which kind of induces clotting and blocks it off. So it blocks the passage for where the blood can kind of go through. And so the consequences of delay in kind of getting, that surgical intervention done for the patient is high risk of bleeding. So that can, obviously that's another hemorrhage on top of the hemorrhage they already have, and this is often fatal. And then we have permanent cognitive or physical disability. So Salma went over, some of the things that can happen with a hemorrhage. So intracranial pressure and the brain, just the size of the brain and also the blood. So she went over how the brain takes up 80% of the space, blood takes over 10%, and then intracranial fluid, cerebrospinal fluid, takes up 10% as well. So that is a very balanced type of thing. So if it increases, if anything increases or decreases, the other two have to kind of balance that out. And so by bleeding again and again, that will cause a disbalance of how much mass, how much space the brain itself and the intracranial pressure, intracranial fluid can take. So here's the coiling. So this is the aneurysm, obviously, in the blood vessel. And so a catheter kind of supplies a coil which kind of blocks out the aneurysm. So then all the blood that's flowing cannot go inside because the coil is blocking that passage. And a clip is kind of like this. So here we have the cerebral artery, and we place a clip right here to kind of block it off. And so the blood can only flow in this part or that part and not here. So then it won't increase in size. Okay, now we have acute hydrocephalus. So acute, basically what it means is that it just happens. And it happens like it kind of arises. It's not a very chronic condition. Chronic meaning that it's kind of it's lasted for 3 or more months, but acute is like it's just started and it won't last that long. So that's when certain things can happen to a patient which causes these type of conditions. So basically what an acute hydrocephalus is it's a life-threatening emergency condition caused by a sudden and rapid buildup of cerebrospinal fluid in the brain's ventricles, which leads to increases in intracranial pressure. So we went over just now the Monroe Kelly doctrine, and what it says is basically if one thing increases, intracranial pressure will also increase. So symptoms include severe headache, rapid decline in consciousness. So either it could be drowsiness or a proper coma, setting sun, eye signs, so eyes are looking downwards, and vomiting. So surgical details for acute hydrocephalus. So some things that neurosurgeons can do to kind of cure it is placement of an external ventricular drain, EVD. And so that's what it's used to kind of treat this. So the cerebrospinal fluid can be drained through this. And it involves inserting a thin catheter into the brain through a burr hole used to drain cerebrospinal fluid, which is what I've said. And then consciousness of delay. So the consequences of delay is that it leads to irreversible brainstem compression. And so that can lead to respiratory arrest and death. So here it is. So here the drain's kind of placed into the ventricles of the brain. And it's then the cerebrospinal fluid is kind of collected into a bag to kind of drain the increase in intracranial increase in cerebrospinal fluid. So then the intracranial pressure can go back to its regulated levels, and so then we don't have the problems that acute hydrocephalus can cause. So yeah, now we'll look at managing intracranial pressure. So what is intracranial pressure? So that is basically forces exerted by brain tissue, blood, and cerebrospinal fluid against the interior of the skull. So obviously we have the brain, then we have the skull. So interior meaning the brain kind of pushing into the skull, and that pressure, that forces exerted is what is known as intracranial pressure. And so because the adult skull is rigid and it cannot expand, more like a brain, like a baby's brain can, um, it can cause an increase in volume from swelling, from tumors, or from hemorrhages caused by pressure to rise rapidly. So obviously we only have a fixed amount of space in the skull, and that is precisely for the brain tissue, the blood, and cerebrospinal fluid to kind of just sit there. But if we have any sort of neurological condition, such as cerebral edema, or tumors, or hemorrhages, we get an increase in intracranial pressure because there's no space for that, you know? And then so high intracranial pressure can cause something known as herniation, which is basically where the brain is physically pushed out into the spinal canal. So it compresses the brain stem, which controls the breathing and your heart. So it controls like the kind of things that you don't really uh consciously like control, so they're subconsciously controlled by the brainstem. So if herniation causes the brain to kind of physically get pushed down and compress the stem, it can cause to sudden respiratory attacks or even, cardiac arrest. Then we have high pressure. So this can exceed the body's ability to kind of pump blood into the brain, causing ischemia. So that is basically a lack of oxygen. And this can cause a widespread brain tissue death. So this will not only affect the cognitive side of the patient, but also physical side of the patient because it depends on where that ischemia happened. and what parts of the brain kind of are dead now, like the brain tissue. So if left untreated, the intracranial pressure can cause permanent brain injury, seizures, and permanent blindness by damaging the optic nerve. So obviously we're saying a huge range of symptoms, but it kind of depends on where that, intracranial pressure is affecting, like what part of the brain it's affecting. So if it's affecting here, it will lead to like a bit of confusion, shallow breathing, increased blood pressure and headaches. So yeah, and then we have surgical intervention for acute pressure relief. So what can we do to kind of decrease that intracranial pressure? So they need to perform, we like neurosurgeons need to perform invasive procedures to create space or to either remove excess fluid. So we could use decompressive craniectomy. So that is where a large section of the skull, typically 12 centimeters or larger, is removed. So this is a very invasive surgery. And the underlying, dura mater, the membrane that kind of covers the brain, is cut and then expanded using a graft. And this converts the skull into an open system. So basically, the large section of the skull is removed. And the dura mater is kind of expanded using a graft so that it's like it's covering the brain, but the brain is exposed. Like it doesn't have, the skull kind of keeping it hidden. So the skull is just removed and we just have that. So it lets the brain tissue swell safely outside of normal boundaries. So you would see in the ward that, like for patients that went through a craniectomy, you would see their actual head like opened, the skull taken out, and then their brain is kind of oozing out. And this is so then it can swell safely without having, those issues of seizures or, paralysis. So it's just to kind of let the brain kind of swell without having those permanent damages. And then we have external ventricular drain, which we just went through. So that's where they, do the burr hole in the skull. So they make a little hole in the skull and they pass down a catheter through the brain tissue into the lateral ventricle. And then this is used to kind of drain out the excess cerebrospinal fluid, which could be caused by acute hydrocephalus, which we just talked about. Then we have surgical interventions, so long term, so chronic conditions. So this is where conditions that last more than 3 months. So conditions like hydrocephalus, where the cerebrospinal fluid builds up in the brain. They require permanent surgical solutions to kind of maintain the fluid levels because, as we said, intracranial pressure would increase and that this will lead to many issues. So some type of interventions that neurosurgeons do is cerebrospinal fluid shunting, which is a permanent internal tube known as a shunt, and this is implanted to divert the excess cerebrospinal fluid from the brain or spine to another part of the body. So it's to kind of say, okay, you need to go here and not stay in the brain because it's causing a huge impact. So this could either be the abdominal cavity where the body reabsorbs it. And the surgeon tunnels the catheter under the skin from the head to abdomen and installs a one-way pressure regulated valve to kind of prevent backflow. So if you've done GCSEs, if you've done A levels, or you're doing them currently, you would know that veins, they have valves to kind of prevent backflow because the blood is going through a very low pressure, so there's a chance that there might be some backflow, and that's why veins have valves and but arteries don't. Right, so that's just some GCSE revision for you there. But the surgeon tunnels this in under the skin. Then we have venous sinus stenting. So if the pressure is caused by narrow drainage veins in the brain, the surgeons can place a mesh stent to widen the vein and improve the outflow of blood and the cerebrospinal fluid. So this kind of increases the volume at which blood and cerebrospinal fluid can kind of go through. And under live X-ray guidance, a micro catheter is threaded into through the femoral vein. You don't really need to know what that vein is. In the growing up into the dural venous sinuses to deploy the self-expanding stent across the narrowed area. So what it's basically saying is that they put it in a catheter. So this is showing the catheter, and there's a valve, so then the outflow of the catheter can now lead the cerebrospinal fluid somewhere else other than the brain. Okay, now we'll look at the role of neurosurgeons in kind of managing traumatic brain injuries. So obviously there's decision making. They have to make high stakes decisions on whether to operate or not, what surgical approach or technique or pathway they need to go through, how to treat the complications that may arise before, no, sorry, during or after surgery, and how to implement risk adjustment for individual illnesses. So, neurosurgeons have a variety of patients that can come. A lot of patients, as we're talking about today, will have TBI, they will have traumatic brain injury, and they need to decide in that kind of quick moment, they need to decide what to kind of operate, they need to diagnose as well, and what type of pathway they will take, because some neurosurgeons, they take it from the nose, the nasal passage, some take it from just the head. There are many different types of ways that neurosurgeons can perform a neurosurgery depending on the condition that the patient presents. So a neurosurgeon's decision can be affected by time constraints, obviously, because in emergencies, it kind of reduces the capacity for extensive deliberation and planning and, MDT meetings to kind of discuss with the patient, because obviously the patient is coming unconscious. They need the surgery now, or else they're going to have lifelong consequences. And the surgeon's experiences and the personal values and training as well. So this can lead to a variety of treatment recommendations for the same patient by a variety of different neurosurgeons. And predictive analytics describes the application of data science to kind of support clinical decision making, such as risk stratifying patients before surgery. So because some patients may have other illnesses as well. And so they need to kind of decide what type of route would be the best. So if someone has, like a heart problem, they need to kind of think about what if they go through a heart attack in the middle of the surgery, because that does happen sometimes. And identifying patients at, high risk for readmission. So if any complications arise or any like conditions arise in the patient after the surgery, they kind of need to kind of plan that future, and predict the likelihood for a favorable patient outcome, because as you may know, neurosurgery is very high stakes and very poor outcomes type of surgery. So um, you will need to kind of predict a prognosis for the patient. The use of artificial intelligence as well is quite prominent now. It's growing, and so with live streaming, medical record data holds the promise of improving neurosurgical judgment by addressing some of the disadvantages of decision-making tools. One other thing that can impact decision making of a neurosurgeon is the sleep that they're getting, the mood they're in, because neurosurgeons are still human, and so they will make human error in decision making in the surgery itself and also just in general. So Yeah, so that is something to consider, and to consider whether AI could be good to use in with the neurosurgeon to make a decision, um, especially considering the lack of time that they would have for that decision-making process. We have operating urgently, obviously. So most neurosurgical emergencies involve either diversion of cerebrospinal fluid, which we went over, or control of intracranial pressure or decompression of cranial nerves. So they need to perform these, treatments. Um, they need to perform the neurosurgical treatment as soon as possible, or else there will be, many consequences that could arise. And so the risk of these emergent surgeries are weighed heavily against potential benefits to kind of decide whether, a surgery would save the patient. Because sometimes, traumatic brain injury can lead to death, and you can't do anything about that as a neurosurgeon, as a doctor, you can't for some of the cases. And discussions with the family of the patient are always involved in the final decision making. But sometimes we may not have time to wait for the family of the patient, and we might just need to kind of judge with our own medical judgment and expertise. Um, and yeah, and then we have many interventions are effective, and most patients do return to full function, but there are many neurosurgical procedures um, that could leave the patients being severely disabled and dependent, because, as I said, neurosurgery is quite poor in terms of outcomes. And there are many deaths that are involved with neurosurgery, which is what makes it a hard field to kind of get into and to survive in. Then we have working with trauma teams. So neurosurgeons and trauma surgeons work together to kind of start and manage the neurological injuries. They perform rapid assessments to determine the extent of injury and focus on evaluating and stabilizing bodily injuries with immediate life-saving procedures. So we'll go over some rapid assessments that they do, such as the Glasgow Coma Scale and the ABCD. Um, Strategy that they use. They will also continuously monitor the patient's change in heart rate, pulse, blood pressure, and oxygen levels, just basic things that we need to make sure that the patient is kind of doing okay in terms of the blood and the heart side of the things, because that is what contains life. Then we have incremental progression of advanced treatment as patients' response to stressors in the physical environment is gauged. Um, so depending on the patient's like consciousness, appropriate treatment then follows. So the brain tries to maintain its own homeostasis separately from the regulation of other body functions. So after an incident or severe injury, the brain is more susceptible to physical stressors throughout the body. And that's why, doing neurosurgical intervention is important. So yeah, now we'll look at some initial emergency approaches. So one of them being Glasgow Coma Scale, as I just mentioned. So it's basically a clinical tool used to assess a patient's level of consciousness, and it was developed in 1974 by neurosurgeons in Glasgow. Commonly, it's used to kind of used in TBI during emergency assessment, which is done by neurosurgeons and trauma surgeons and other healthcare professionals. And it helps doctors determine the severity of the brain injury, and it can also help guide treatment decisions. So clinical importance is obviously it helps with urgent decision making. It determines the need for intubation or neurosurgical referral. So intubation is basically an insertion of the tube to kind of open up the airway. Um, so that is to kind of help the patient breathe, or either to connect the patient to a ventilator if they need that support in breathing. Um, so yeah, and it's used repeatedly to kind of monitor neurological deterioration in many other scenarios as well. So GCS measures three responses. So it measures eye opening, verbal response, and motor response, which is kind of what defines consciousness in a patient. So here we have a diagram of the Glasgow Coma Scale, and so we can see here the higher the number, the better. The better because it means that there's either little to no TBI, um, and the lower it gets, the worse the severity of the TBI is. So best eye response is basically if they can blink on demand and also just blinking at baseline, because obviously everyone blinks without thinking. So if the patient can do that, they're pretty much fine in terms of um, eyes. Then we have best verbal response. So they're oriented, they can talk, but if they're a little confused or they're talking in a manner that's incomprehensible because they can literally not control their speech, that could be a sign of TBI or any other neurological condition. Then we have best motor response, so they can obey, like they can obey commands for movement. So, a doctor may say, "Oh, lift your hand up." So if they can do that, that means that they're fine, they're conscious. Um, Purposeful movement to painful stimulus as well. Um, and they kind of can the patient can withdraw from pain, but if they can't and they're kind of just they have a decerebrate posture, it could lead to TBI. So then they add up all these scores for all these sections, and then this is what they use to kind of determine the severity of the uh, traumatic brain injury. Then we have the ABCDE method. So this is used by doctors, surgeons, just anyone that is a healthcare professional to kind of see the severity of critically injured patients and what we could do to kind of save them and give them the medical intervention they need. So first is that they approach the patient in a situation that is safe to do so. They will use the ABCDE approach to assess and treat the patient. Then they do a complete initial assessment to kind of see their motor, in terms of speech and also just cognition, to see their ability in that. Then they treat life-threatening problems before moving to the next part of the assessment. So if there's an obstruction in the airway, that needs to be fixed because if they can't breathe, they might die. Then we have assessing the effects of treatment. So they might perform intubation to kind of open up the airway so then they can breathe, and then they assess the effects of that. If they can breathe, if they can, return back to the breathing that they need to do. Um, then you also need to know when to recognize where you'll need a little bit of extra help. So then they call for appropriate help early. So this is like usually for paramedics that, arrive at the case, and then they need to take, some time to kind of get to clinical intervention to assess the patient. So first steps, so yeah, approach the patient and then, wear gloves if appropriate. And then if the patient's awake, you'll ask some questions like, how are you, to kind of assess if they can speak articulately and, if they're conscious. But obviously, if they're unconscious or they collapse, do give them a light shake to see if they awake, or if a patient responds normally and it shows their airway is opened and breathing and they're breathing and they have brain perfusion, which means that everything is flowing perfectly in the brain, which means that they're conscious. So if the patient is unconscious, unresponsive, and they're not breathing normally, occasional like gasps are sign of restricted breathing. They need to start CPR to kind of according to the resuscitation guidelines. Then we have monitoring the patient's vital signs. So this can be, the blood pressure, oxygen levels, stuff like that, by attaching a pulse oximeter and ECG monitor and non-invasive blood pressure monitor as well. And then insert an intravenous cannula as soon as possible to take bloods and use them to investigate patient condition. So this is specifically for when a patient is presented with traumatic brain injury. So the previous slide was for just any issue, but this is specifically for patients that may have traumatic brain injury. So A is airway obstruction. That is an emergency because untreated airway obstruction can lead to hypoxia. And this can lead to risks. It risks damaging the brain, heart, kidneys, and it can cause cardiac arrest or even death. So we need to look at signs for airway obstructions, which may mean abnormal breathing patterns, no breathe sounds from the nose or mouth. So you may see paramedics kind of lean to hear the person breathing. If they can't hear, that means that they may have an airway obstruction. Then we need to treat an airway obstruction as a emergency because most cases require simple airway clearance methods, including airway suction or insertion of oropharyngeal or nasopharyngeal airway. So an oral means oral, so putting in the, intubation using that passage for the intubation process, and nasal pharyngeal airway as well. Then we need to give oxygen at a high concentration to kind of balance that gap in where there was an airway obstruction, and this provides a high concentration of oxygen using a mask with oxygen reservoir. And so we need to provide that high oxygen or concentration of oxygen. Then we have breathing. So during immediate assessment of breathing, it is vital to kind of diagnose and treat immediately life-threatening conditions. So we need to look, listen, and feel for general signs of respiratory distress, sweating, or use of accessory muscles of, respiration and abdominal breathing. Then we need to count the respiratory rate. So the normal rate is about 12 to 20 breaths per minute, and any value higher indicates that the patient may be deteriorating suddenly. And assess the depth of each breath. So, like a normal breath may be a little deeper than a breath that is not very, that a patient may have if they have a condition. So the pattern, the rhythm of respiration, and whether the chest expansion is equal on both sides. So if it's not equal, then that could mean that there's a chest deformity. 4 is specific treatment of respiratory conditions, depends on the cause, but critically ill patients should be given oxygen regardless. Then we have circulation. So in almost all medical and surgical emergencies, consider hypovolemia, which means a critical change in blood volume, to be a primary cause of shock. So yeah, unless there are obvious signs of a cardiac cause, give intravenous fluid. So this is basically intravenous fluid is used to kind of balance out the electrolyte balance again, because it's quite important that it's balanced for obvious reasons. To any patients with cool peripherals, so that means if their fingertips or their toes are cold, and if they have a fast heart rate, so that could indicate, some problems with circulation. So stuff that medical, professionals look at is the color of their hands. So are they blue, are they pink, are they pale, or are they mottled? Assess the limb temperature by feeling the patient's hand. Are they cool or warm? Assess the state of veins. They may be underfilled or collapsed when hypovolemia is present. And 4, they need to count the patient's pulse rate. So this is using a stethoscope. Palpate peripheral and central pulses to kind of assess for presence, rate, quality, regularity, and equality. And then measure the blood pressure of the patient as well, and the specific treatment of cardiovascular collapse depends on the cause and what, the medical professional kind of saw as well. Then we have disability. So common causes of unconsciousness include profound hypoxia, hypercapnia, which means a very, very high amount of carbon dioxide in the blood, cerebral hypoperfusion, which means like there's not much cerebrospinal fluid kind of circulating the brain, which could have an impact on how much oxygen is being put into the brain tissue. And so recent or like the recent administration of sedatives or analgesic drugs. So analgesic drugs are basically a very fancy way of saying the painkiller drugs that we take to kind of reduce the pain. And sedatives can also have a similar effect. So they need to review and treat using the ABCs, and they need to exclude or treat hypoxia and hypotension. And then they need to check the patient's drug chart for reversible drug-induced causes of depressed consciousness. And so this is where they give an antagonist where appropriate. They need to examine pupils, so the size, the if both pupils are dilating and constricting at the same size, because in certain conditions like TBI, you might have one eye that is dilating a lot and one eye that's constricting a lot, and then the reaction to light. So obviously, if there's a light being shined, most normal eyes would constrict, and if it's quite dark, then they will dilate to let in light. Then we need to make a rapid initial assessment of the patient's conscious level using an ACVPU method. So are they alert? Are they confused? Are they responding to vocal stimuli? So the doctor saying, hey, can you respond? That is vocal stimuli. Painful stimuli, or are they fully unresponsive? Then they measure blood glucose by using a rapid finger prick bedside testing method, and keep unconscious patients in a lateral position if their airway is not protected. So lateral meaning lying down. Exposure, so that is E. To examine the patient properly, full exposure of body may be necessary. So yeah, so if active bleeding is identified, you need to estimate the total blood loss and reassess for signs of hypovolemic shock, which we just talked about. We need to measure the patient's temperature. So if the patient has temperature that is higher than 38 degrees, it may be due to an infection. Hypothermia, which is typically less than 36 Celsius, may be seen in patients who have been immobilized by their injury for a prolonged period of time. So if they've just been hit by a car, and they can't move, they may experience hypothermia and a decrease in their temperature. And then we have treating other injuries identified, and involving appropriate specialties, so orthopedics to reduce a fracture, for example. Okay, now we'll look at imaging TBI. So CT scans are normally used for TBI. CT scans can look for hemorrhages. So this picture of a CT scan shows a hemorrhage. So it shows blood being formed in the lateral ventricle. So this is a type of hemorrhage. Cerebral edemas, which is brain swelling. So this is a normal brain, and that is brain edema. You can see the structures like the ventricles here. You can see them very clearly, but in an edema, everything's kind of just swelled up, so you can't really see the structures that well. And this will obviously lead to intracranial pressure increase. Then we have midline shifts. So this is how the brain is kind of divided into two hemispheres. That is the midline. So that's the ideal midline indicated by the red dashed line. But midline shifts may be where a patient presents with their midline being shifted to one side. So this is caused by hematomas sometimes. So hematoma meaning hemorrhages. Um, and yeah, then we have skull fractures as well. So this you could see, maybe if you lean close, you can see a fracture in the skull right there. We'll look at ethical considerations as well. So possible scenarios could be where prognosis is uncertain. Sometimes surgery does not mean cure. It doesn't necessarily mean that it's going to fix everything. And it could potentially worsen the condition and may not end up improving the quality of life of the patient. And it may lead to severe disability sometimes, paralysis or other permanent complications such as auditory or vision loss or even seizures that will last a lifetime. Um, in emergency situations, you may not have the time as a healthcare professional to get consent from family members of the patient as well. So you kind of need to use your own medical judgment. Allocation of ICU resources. So sometimes a shortage of beds or neurosurgical teams may become an ethical dilemma. So how do you decide who gets the last bed? And this is a very common ethical scenario that you could be asked about. So, what ethical principles could be used in these situations? We have autonomy and best interest of the patient. So, patients are often unconscious or confused, so they lack capacity momentarily, obviously because they've just gone through a traumatic brain injury. They may not be conscious, may not have the capacity to give consent and make an informed decision because they're unconscious. Doctors may need to make decisions based on their medical expertise in the patient's best interests. Then we have beneficence, so acting in the patient's best interest. In TBI, rapid surgery may save a life or reduce disability. So doctors must act quickly to maximize benefits. And then we have justice. So ICU beds, neurosurgical teams, and operating theaters are limited. So decisions sometimes involve prioritizing patients, unfortunately. Then we have again best interest of the patient. So surgeons may operate by making decisions about quality of life, survival chances, family input, and possible prognosis or comorbidities and previously expressed wishes. So if a patient has said that they do not want to be resuscitated, sometimes you need to do that. You can't resuscitate them um, if they have previously expressed wishes of not being resuscitated in any scenario. Okay, future of TBI management, we'll go over this quickly. AI for CT imaging interpretation. So that is where AI could be used to kind of identify and diagnose the patients with what type of TBI injury they have. Then we have advanced neuromonitoring, so to see, the neurological condition of the patient. Then we have neuroprotective drugs. This is being talked about a little. And so this is basically to kind of make drugs that prevent decline in neuronal function. Then we have robotic surgery, so increased dexterity. It will help with improved outcomes because it reduces the chance of human error. Algorithms for triaging and prioritizing patients. So utilitarianism is a type of philosophical idea where it's used by the NHS, and it's to say that you need to do the greatest good for the greatest amount of people. So sometimes that means that you need to kind of do something that will help the most amount of people, even if it's kind of affecting badly like a smaller majority of people. So this idea could be used in medicine as well. Okay, this is a case study. This was supposed to be interactive, so we're gonna try and answer in the chat. I have a couple questions. So this is a case study that I made. So a 46-year-old woman presents in the A&E after being severely injured in a car crash, and she has been rushed into hospital about an hour ago. They performed a CT scan, and they have diagnosed her with acute epidural hemorrhage, which is something we went over, and she has a GCS score of 80. Oh, sorry, 8. So, what does a GCS score of 8 indicate? Is it A, mild brain injury, B, moderate brain injury, C, severe brain injury, or D, normal neurological status? So I would love if you could answer this in the chat. I know we're going a little bit over time. Um, but yeah, let's go through this quickly. Thank you for those that are answering the chat. Yeah, so we have seen some C's, and that is correct. So anything lower or equal to 8 is considered severe in terms of the severity of brain injury. All right, so the same case scenario, we'll just say, what is the next most appropriate step? Is it A, observe and repeat CT in the next 24 hours, B, start antibiotics and admit to ward, or C, discharge with head injury advice, or D, urgent neurosurgical evacuation? So is it a craniotomy? I'll give you about 30 seconds. So we're seeing a couple D's and a couple C's, and the answer is D. So in this situation, obviously, she's been here for an hour and she's been diagnosed with acute epidural hemorrhage. And her GCS score is scaringly low. So we need to make sure that we can perform a neurosurgical evacuation as soon as possible. So yeah, they can deteriorate quickly due to atrial bleeding, and this may require immediate neurosurgical intervention. Okay, which factor most strongly improves survival in epidural hemorrhages? Is it A, the age of the patient, B, rapid diagnosis and surgical evacuation, C, antibiotics, or D, waiting for neurological improvement? Yes, you're absolutely right. It is B. Yeah, so that's all I have for head, TBI. I'm wondering if Neha can take over and just go over her well-being section part, because obviously we are running over time. So apologies for that, but I hope you enjoyed this part of the seminar. It was quite content heavy, as we just saw. But yeah. Thank you so much. I'll see if Neha can do her part.
I've requested to take control.
Yes,
Okay. Can you see? Oh, wait. Can you see my screen?
not yet.
Um, what about
Yeah,
now?
yes, I can
Okay,
see.
so I'll try and make this quick. So, hello, my name is Neha, and today I'll be presenting on the topic of resilience in high performance medical careers. So, why does resilience matter in medicine? Resilience matters because it allows healthcare professionals to maintain a good mental and emotional well-being without burnout, especially in the face of difficult challenges and in high-pressure environments. This has a positive effect on improving the quality of care given to patients, which in turn does improve patient outcomes. Not only do doctors have to do their best when it comes to treating patients, but they also have to handle the emotional weight of caring for them on top of managing a heavy workload. Furthermore, resilience in healthcare teams is very important as it ensures system reliability and strengthens the ability to work as a team to respond to emergencies effectively. Okay, so there are many ways in which doctors can build their resilience. The first would be to understand their own limits by recognizing times when they need to seek help or take a break to regulate their physical and emotional well-being. Utilizing formal support services like BMA guidance, NHS England, and practitioner health help with this. They can also have a clear separation between work and personal life to help manage stress, as well as build a strong support network that does not just have to be their family, but also colleagues as well. And this can reduce feelings of isolation. There are also more practical strategies like prioritizing sleep, eating nutritious meals, and physical activity, which can improve the ability to handle pressure. Implementing these strategies is important to enhance their resilience and in turn have this translate into better patient care. So, how should we as aspiring medics build up our resilience? First of all, you can do this by reframing your perspective. Instead of viewing challenges as insurmountable, you need to see them as opportunities for growth, asking yourself questions like, what can I learn from this situation? Or will this challenge help me grow? Building a routine, as difficult as it may be, is very important, especially during tough times when you would be feeling overwhelmed. Creating a routine helps you feel more resilient in being productive and having a regained sense of control. In addition, you can also try creating an action plan to define measurable long term goals with quarterly milestones that you can check for progress monthly. But of course, make it realistic. Trust me, I've tried doing 20 different things in one day, which never works out. Practicing mindfulness and engaging in resilience activities is another way as it promotes thoughtful responses whilst enhancing conflict management. There are many ways to do this, which includes meditation, going for a walk, journaling, and self compassion practices. Another very useful exercise you can do is identifying stress triggers, logging them, and creating a rule for when to seek support. Finally, there are the 4 F's of resilience that both aspiring and current medics should be thinking about. Remember to fuel your body, refuel with good quality sleep, change your form when you feel stressed, and focus on solving your worries when you can. Thank you for listening to my presentation.
Thank you so much, Neha. That was really, really helpful, like always. I've put in the attendance form, and yeah, I hope you guys enjoyed this week's seminar. Obviously, it did run up a little, and apologies for the technical difficulties at the start of the presentation, but I hope that you guys understood what the concepts was, and hopefully you guys enjoyed it as well. Next week, we may have a guest speaker from who is a consultant orthopedic surgeon. So it would be great if you could recommend other aspiring medics that you may know to kind of attend the session, because it's not every day where you get to kind of speak or see or even share insights with a consultant orthopedic surgeon. So yeah, that will be taking place at our normal time, 6 to 7 p.m. GMT. And yeah, I hope you guys enjoyed this week's seminar. I'll stay at the end to answer any questions that you may have. Thank you so much again, and yeah, see you next week.